In this video, I'm going to talk about scleroderma-associated pulmonary arterial hypertension. So this is scleroderma-associated pulmonary arterial hypertension. So if you remember from the classification of pulmonary hypertension, scleroderma is one of the causes of group 1 pulmonary hypertension. So that's called pulmonary arterial hypertension, or I think of it as primary pulmonary hypertension. So first of all, let's talk epidemiology. So what's the prevalence of pulmonary arterial hypertension in scleroderma? So it's actually pretty prevalent. It's estimated to be, the prevalence is estimated to be around 10 to 15%, which is pretty frequent. That's 1 in 10, at least 1 in 10 patients are going to have this. The reason it's important is that scleroderma is actually the leading, not scleroderma, but pulmonary arterial hypertension is the leading cause of death in patients with scleroderma. So what's the data to back this up? Well, the 2-year survival rates, once you're diagnosed with arterial hypertension, it's somewhere on the order of 64 to 89%, which is not great, because on the flip side, if this is survival, on the flip side, somewhere between 11% to 36% of patients are going to die within 2 years of developing pulmonary arterial hypertension. And that's really bad, because that's anywhere between 1 in 10 to 1 in 3. So that's not good. So what are the risk factors for developing pulmonary arterial hypertension if you have scleroderma? So it depends on several things. So first of all, it depends on the type of scleroderma. So if you have a long-standing scleroderma, you're at increased risk. This is pretty self-explanatory because a lot of things, the longer you have them, the higher your risk of disease. So some people clump age into this. The higher age, the greater your chance of having this guy, which makes sense. The higher your age, probably the more chances you've had this for a long time. So these kind of go hand in hand. The second is the limited. If you have limited cutaneous scleroderma. So this is interesting. This is really patients who have predominantly the skin symptoms, so the sclerodactyly, if they have telangiectasias, so the vascular manifestations, and if they also have Raynaud's, which is, as you remember, is if the person's hands go white in the cold, this is also a vascular kind of manifestation of the disease. So if these are the predominant, if this is a predominant presentation of scleroderma, then you're at an increased risk of pulmonary arterial hypertension. Also, there's some demographic things, graphic factors that play into this. So as we talked about above, your age, and also if you're male. So this is one of these things that the way I think of it is, if scleroderma is more, it's a, you can group it with the kind of like the autoimmune diseases, or the rheumatologic diseases, and usually those have a female predominance. So if you're male and you have this, that's kind of like an unusual thing, and that puts you at an increased risk. Because if you aren't predisposed to it, but you have the disease, the scleroderma, then I kind of think of it as that your disease is more severe or more serious. I know that's probably not the right way to think of it, but it helps me remember it. So these are kind of the type and demographic ones, but there's also some data and some labs, let's call it labs and tests, that can stratify you based on the risk. So first is the DLCO, so the diffusion capacity, which is kind of a combination of things. It's a combination of how much lung parenchyma you have, and also how thick the parenchyma is. So this is kind of probably a proxy of pulmonary fibrosis, which occurs in scleroderma. It's kind of a proxy for how developed the disease is. But this is actually a very important risk factor. So there was a study done which took patients with scleroderma and it broke them down into two groups. This is a cross-sectional study design for all you people studying biostats for step 2. So they broke patients down into patients without pulmonary arterial hypertension and with pulmonary arterial hypertension. So the controls had a DLCO of about 81%. And the patients that did have the pulmonary arterial hypertension had a DLCO of 52%. So this is a very large difference, and in the study it was also determined to be statistically significant. So the DLCO is a very important marker to risk stratify patients. Also serologies, this is very important. So if you have the following antibodies, it increases your risk. So anti-centromere antibody, the anti-U1 ribonuclear protein antibody, and the nucleolar variety of the ANA. That increases your risk of having this disease. There's some newer studies which are trying to look at NT-proBNP or hepatocyte growth factor assays. So these levels, but none of them have really been validated. So this is still research that's up in the air. Okay, so now that we've talked about all of this, all the epidemiology and risk factors, how does this play into clinical medicine? Well, since this is so prevalent, and it's, pulmonary arterial hypertension is the leading cause of death in scleroderma, this is something that you want to screen for. So if you have a scleroderma patient, even if they're asymptomatic, the moment they come into you, you want to start, we want to start close follow-up. So even if they're asymptomatic, you want to get the full pulmonary workup on them. So you want to get PFTs, you want to get spirometry, lung volumes, DLCO calculation, all of this. And you get this annually. So you can become a little bit more lenient with it if they have normal PFTs for at least 3 years and they remain asymptomatic during this time. And I think if they have DLCO that's normal for at least 5 years, then you can space it out to, every 2 years. If PFT is normal for at least 2 years and DLCO normal for at least 5 years. As we talked about before, what do we screen with after this? What are the other 2 screening tests that we can use? We can use echo and we can use the right heart catheterization. So when do those come into play? Well, this is kind of least invasive, least expensive stuff that you can do. You're going to save those other tests for patients that are actually symptomatic. So the moment they develop symptoms, you get an echo. And what are these symptoms that they can develop? So there's stuff that you're going to pick up, or you might pick up, depending on how good you are at physical exam skills. You might pick up a loud P2. This is like one of these subtle findings that just happens because of the increased pressure. A patient might come in with symptoms such as dyspnea, maybe dyspnea on exertion. And I'll say, hey doc, I have this, I'm having difficulty breathing, when I'm walking I get kind of short of breath. And you say, all right, off to the echo you go. And then, something like right heart failure, syncope, these are, hopefully it doesn't get to that point. Hopefully that's not their first presentation with their disease. It might happen. If you have a scleroderma patient that's not great about follow-up, maybe they don't do this annual testing even though you are begging them to do it, they might come in with something like this and they'll be like, oh, I didn't think it was important when I first started having difficulty breathing. I just, I passed out at one point. And you're like, well, why didn't you come in earlier? So, all right. So you do an echo. And the echo can estimate the pulmonary arterial pressure like we talked about. And if you see any abnormalities on this echo, there's a very low threshold to jump to right heart cath, which is a diagnostic test. So this talks about screening. Screening isn't very good if you don't have any way to treat this. We don't want to screen for diseases for which there's no treatment. The treatment for this, unfortunately, though, is, it's not great. There's no definitive treatment. It's really just, it's treating the underlying disease. It's support with, oxygen, support with diuretics to reduce the pressure, support with digoxin in case there's heart failure. So also the treatment is also kind of aligned with other treatments for pulmonary arterial hypertension. So like endothelin-1 antagonists, so such as like bosentan. It's a very important treatment modality. And eventually it's lung transplant, unfortunately. So that's once the disease progresses enough, that's the only option that patients have. And unfortunately, that's what they have to resolve to. So the prognosis isn't great. So really, it's unfortunate. It's one of the reasons why scleroderma is a very devastating disease. So, yep, that's it. That's kind of the overview of pulmonary arterial hypertension and scleroderma.